Hello everyone, and thank you for accepting the European Tuberous Sclerosis Association's invitation to this DEA World Forum webinar, a web version of the DEA, disseminating expertise and achievement it stops. My name is Carla Pladrowski. I lead the DEA project with Michaela Rosenberg. Today's special session, DEA World Forum, is entirely dedicated to lymphangioliomyomatosis, as June is LAM Awareness Month. There are two forms of LAM, sporadic LAM and LAM associated with TSC. Possibly 250,000 women worldwide have this rare cystic lung condition, leading to a loss of lung function. Many women are currently either undiagnosed or misdiagnosed. We have now opened the chat box, so feel free to post in any queries. We will endeavour to answer all of them. We will also be recording this webinar. We will publish on social media as soon as possible. Today, we are proud to have with us two prominent figures in the world of LAM, in its treatment and in research. Doctors Sergio Harari, Ospedale San Giuseppe, Milan, Italy, Souheil El-Chemal of Brigham and Women's Hospital, Harvard Medical School, USA. Now over to Dr. Chris Kingswood, Honorary Consultant and TSC Specialist, St George's Hospital and Medical School and Brighton and Sussex University Trust UK, and moderator for this special session with Dr. John Bisler, Director of the TSC Clinic at Le Bon Air Hospital, Memphis, USA.
Thank you very much, Carla, and welcome everybody to the symposium. We're very privileged to have two expert speakers today. Our first is Professor Harari, known in the UK as Dr. LAM Italy. And we're looking forward to what he has to say. Without further ado, I think I'll just let him get on with it, and then we'll moderate questions and at the end of each session. So there's two presentations, and we'll have some questions at the end of each one. Thank you. Professor Harari.
Yeah, Professor, you have to unmute yourself. No.
Okay.
Okay. Yes. Yes.
So thank you very much. Thank you for inviting me. It's a pleasure to be here with so distinguished faculty. I want to share with the audience just a few ideas regarding possible novel treatments for LAM. These are my conflict of interest. So the current indication for treatment with sirolimus in LAM are patients with abnormal lung function, patients whose function is declining, and problematic chylous effusion and lymphangioliomyomas. However, we do know from previous study that patient after discontinuation of this drug restart to decline. And we do also know that for this reason, patients have to be treated long life. On the other side, there are some patients that do not respond to sirolimus, and after an initial stabilization, like in this example, they fail to treatment and start to decline despite sirolimus therapy. So we have, I don't want to enter in details, but we have now a certain knowledge of the pathogenesis of the disease and of the molecular mechanism that can regulate LAM cell proliferation. And in this side, we can also have some possible chance to interact to the pathogenesis of a disease with different approaches. One approach is to enhance autophagy. LAM cells are predicted to have low level of autophagy because mTORC1 activation. And autophagy allows cell to produce energy and maintain essential molecules through the use of breakdown products. In LAM, we have a decrease of autophagy that can reduce cell survival. Sirolimus blocks the further growth of LAM cells by inhibiting protein translation, but simultaneously promotes the survival of LAM cells by inducing autophagy. So the combination of mTORC1 and autophagy inhibition using rapamycin and chloroquine seems to be more effective than either treatment alone in inhibiting the survival of tuberous null cells, growth of TSC2 null xenograft tumors, and development of spontaneous renal tumor in TSC2 positive negative mice. So we have some data from animal models. And we also have from one of the speakers of today an interesting study on the association of sirolimus and hydroxychloroquine in patients with LAM, an association that was well tolerated and seems to possible have a certain effect on stabilization of FVC and FEV1. So we will need more studies on that sense to understand if this association can give something more than the simple treatment with sirolimus. Another possibility is to use SRC kinase, and a phase 1 study with saracatinib has been completed, and another more advanced phase 2 study is still ongoing, and so this is another area of interest. On the other hand, we can interact with different molecular mechanisms. In the alternative phase of cell proliferation with drugs like resveratrol. Resveratrol can interact again with this mechanism of autophagy, and in vitro can reduce cell migration of LAM cells. A study has been started on resveratrol in combination with sirolimus, with at least 20 weeks of treatment. 24 weeks is the duration of treatment goal, with primary outcome serum GVDF level, and is a dose finding study. Nintedanib, that is a drug that is widely used to treat idiopathic pulmonary fibrosis, is a drug that inhibits VEGF, PDGF, and follicular growth factor, that are pathways that reduce tumor angiogenesis in lung and that are very important also in LAM cells. For this reason, we started some time ago a phase 2 open label single arm study, and the study design is similar to the miles. So we have 2 months of treatment followed by 12 months of observation. We included patients with evidence of progression of disease or intolerance or progression despite sirolimus therapy, And the primary outcome measure is FEV1 with several secondary outcomes. We included the last patient last Christmas. So 30 patients were included in the study. I want to present only the data on side effects. We had some patients that drop out for several reasons, mainly for toxicities due to liver toxicity, one for declining lung function, other for abdominal pain. Side effects in 27 patients that already completed the 12 months of treatment were those expected in patients that we usually treat for IPF. So we had only elevation of liver enzyme and hypercholesteremia, temporary diarrhea, and nausea. This is just one case to have an idea of what can happen in some patients. This was a patient that was started sirolimus and started to decline in sirolimus, and when started in nintedanib in this protocol and had a stabilization. But we will need 1 more year to have the final result of this study. PL2 is a rate-limiting enzyme that catalyzes the conversion of plasma membrane phospholipids into PGS, and that play a role in COX inhibition. And we had a COX-2 inhibition trial with celecoxib in LAM, phase 1, open label, single arm. Duration of study was 6 months with 6 months of follow-up. The primary outcome was safety and tolerability. The result of the study were recently published on the European Respiratory Journal by El-Chemal, and the authors enrolled 12 patients with no dose-limiting toxicity encountered, and then with no very severe adverse event, were a good tolerability, but the post-bronchodilator forced vital capacity and FEV1 and the LCO did not change significantly during the study period, but again, this is a pilot study, and we need more data to investigate a possible response of the disease with this kind of approach. Statins are another possibility to investigate and are under investigation some studies. So simvastatin can be added to sirolimus oil and everolimus, and again, very recently a study was published on the combination therapy with simvastatin at a significant dose that was well tolerated, associated with mTOR inhibitor, but the safety was unclear as some patients declined during therapy, and again, we are not sure that this association could be really effective in the management of the disease. The problem of estrogen has been discussed for many years. We know that there is probably a role for estrogen in this disease, and we do know, however, that hormonal treatment did not have any effect on this disease in several trials that have been conducted. Actually, there is a trial ongoing with letrozole, that is an aromatase inhibitor in postmenopausal women with LAM. It's a phase 2 randomized double-blind placebo-controlled study with primary endpoint FEV1 and duration of treatment 12 months. The target enrollment of 25 patients per arm was not met, and the results were not really encouraging. So finally, just to resume, I understand that probably this can seem a list of studies, but there is really an effort of research very important with many different studies that have been recently completed and other that are ongoing. And this is very uncommon for a so rare disease. So I think this is an important point. On the other hand, I think we are learning more and more on how to interact on the molecular mechanism of lymphangial hemomatosis and to try to combine different drug approaches, combining, for example, mTOR inhibitors with other drugs. And our final goal is to cure the disease and not just to treat as we are doing, but is already a very important goal, what we are doing now, what we are achieving, what we are able to offer to the vast majority of women having the chance to stop the disease progression. I will stop here. Thank you.
Thank you very much, Professor Harari. That was great. So I'm sure there's been lots of questions, and I'd just like to ask our moderators, backroom girls, if there's anything that's come up on the chat in terms of questions come in that the...
No, not yet. If you have any questions, please, you can send them in now or maybe later, and then we can also answer them later, but...
Okay, could I ask a question, Sergio? In terms of everolimus v sirolimus, because I've got many patients who have both AMLs, kidney AMLs and LAM, and most of them are on everolimus. Do you think there's any difference in efficacy over the longer term?
No, we published some years ago with colleagues from Harvard a study with everolimus and LAM, and we did not find any differences compared to sirolimus. It was expected to be more tolerated, to have less side effects and toxicity, but we did not. We were not able to find any advantage of everolimus compared to sirolimus, at least in this category of patient.
Yeah, thank you very much. And a question from Professor Bisler to all of us. John, did you want to articulate that, or shall I?
No, sure. I was interested. That was a fabulous talk. Thank you. Did the celecoxib affect kidney function at all in the patients who were in the trial?
I didn't understand, sorry. Saracatinib?
Yeah. Did the celecoxib, the COX-2 inhibitor, did that interfere with kidney function in those patients?
No, I don't think so. I don't think so. There was no serious adverse event regarding kidney function.
And could I ask another question, since we haven't had any others yet, and that's about optimizing the dose of sirolimus. What's your approach to getting the right dose for an individual?
Well, it's quite flexible. We try to reach therapeutic range, but some patients respond to therapy also with lower doses that sometimes are better tolerated. So if the patient is stable Also, with a lower dose, we do not increase it. If the patient progresses, we try to achieve the therapeutic range just to be sure that it's really a progression despite therapy, and that's all. So it's quite flexible. It's also depending on side effects and toxicities.
Thank you very much. And Carla, Mika, any other questions from the audience?
No, not that I see until now. It's okay.
I've given them time to, they'll all come at the end. So
Yeah.
should we move on to the second part of our presentation?
Sure. Yes.
Okay, great. Thank you very much. So for our second speaker, I'd like to introduce Dr. Souheil El-Chemal from Boston. He's another LAM specialist and well known in the field. We're going to move the slide screen.
Yeah.
And so welcome, Souheil. I actually don't see him.
1 second. Yeah, it's coming up. Okay.
All right. All right, can you hear me?
Yes, we can. Thank you very much.
All right, thank you. I should have unmuted before I shared my screen. Well, thank you so much for the invitation. It's a great pleasure to be here. I'm going to talk about fatigue in LAM. You know, there's some things in life you regret immediately, and picking the title was one of them. Right after I said I was going to talk about fatigue, I realized it may have been a mistake, because there's actually not a whole lot of things that we know about fatigue in LAM. Nevertheless, it's a really important clinical problem for women suffering from LAM. And unfortunately, there's not a whole lot we know about it, and there's not a whole lot that we know how to manage it. There's a few papers that directly address the issue of fatigue in LAM, and one of the most prominent one is this paper published about 6 years ago now by Jeff Swigris and his group. What they did was at the Lymposium in 2013, they actually had a group discussion with women with LAM and tried to understand, not quantitatively, but qualitatively, what does living with LAM mean for them? And what are some of the limitations in terms of quality of life that they think are really important and should be addressed? So a group of women with LAM, these were some women with sporadic LAM and others with tuberous sclerosis associated LAM, were divided into 7 focus groups in order to come up with common themes between these focus groups about what is important. And obviously shortness of breath was listed 7 times in the 7 focus groups, but also low energy was all the way up there in terms of importance for women with LAM. And low energy was defined in different ways, but these are some of the things that women with LAM describe low energy as: tiredness, extreme exhaustion, absolutely crushing fatigue. I feel wiped. But this is not just about how describing fatigue was, but also the effects of fatigue on their quality of life. It seems to take up a lot of time just to rest. I don't like being tired. I like who I used to be. LAM is making my life small, my universe small, because of how tired I am. I don't mind asking for help, but I resent it. And as a clinician taking care of women with LAM, a lot of these themes keep coming back when I see patients in clinic, that, you know, this crushing fatigue that they complain about, obviously in the absence of anything to explain it, like normal things we do to explain fatigue, thyroid hormone, anemia, things of the sort. But, you know, intuitively one would think that fatigue will be associated with the degree of lung function decline. And the more lung function decline, the more likely it is that women with LAM will be tired. And that's actually not very true. This is a paper from about a decade and a half ago from Simon Johnson's group, where, as you can see, the shortness of breath is on the left and the fatigue score is on the right. And 1 is no fatigue and 10 is incredibly high fatigue. And as you can see, that even women who almost never complain of shortness of breath had a fatigue score about 5. And even those who complain a little bit of the time of shortness of breath really were fatigued. So although there's some association with shortness of breath and lung function decline, really fatigue is an independent problem in LAM that we need to understand and we need to better tackle in the hope of improving the quality of life of women living with LAM, whether sporadic LAM or TSC LAM. Why I say TSC LAM? Because that same paper from Simon's group has also shown that TSC, women living with TSC LAM seem to suffer more so of fatigue than women living with sporadic LAM. And for a reason that we don't quite understand, but we may have a hint about, and I'll talk about that in a second. So studies that were done at the NIH a while ago had shown that if you do a cardiopulmonary stress test on women with LAM, so basically, you know, women are exercising on a bike, and we're collecting the oxygen and the CO2, and we're monitoring the heart rate, and we're asking them all the time, you know, why do you stop? What's your heart rate? Do you have any chest pain? So about 28% of women, this was 217 women with LAM, both sporadic and TSC LAM, but 28% stopped exercising because of leg fatigue, not because of shortness of breath. And if you combine dyspnea and leg fatigue, that's another 7% of the patients. And 5% of the patients, as you see at the bottom of the screen, stopped because of general fatigue. So if you combine all of these together, fatigue about 40% of the time results in women with LAM stopping their exercise, which is about the same as shortness of breath. So it's a really critical problem and something that, again, we need to understand in order to do better. So obviously complicating the problem is the effects of mTOR inhibitors on fatigue. So this is the paper that Sergio alluded to just a few minutes ago, the everolimus and LAM trial. And that's the only clinical trial in LAM to specifically report fatigue. And as you can see here, about 29% of the patients on everolimus complained of fatigue. So we know that mTOR inhibitors, actually one of their side effects is fatigue. And that's not just in women with LAM. If you look at all the cancer clinical trials that use an mTOR inhibitor, more commonly everolimus than sirolimus, fatigue is an issue in these trials in the context of cancer and not necessarily in the context of LAM. This is by no means an invitation to not take mTOR inhibitors. They're obviously critical for the care of patients with TSC and women with LAM and women with LAM TSC. But we have to be aware that it is possible that mTOR inhibitors could be contributing to the symptomatology that women are complaining of. So what are we doing to try to understand fatigue in LAM? This is a cartoon depicting what we call a level 3 cardiopulmonary exercise test. So this is basically the patient on a bike. We're collecting the exhaled gases. We're measuring the heart rate, we're oxygen saturation, we're measuring EKGs, And we also have a pulmonary artery catheter that's directly samples from the pulmonary artery, measures pulmonary artery pressures, measures cardiac output. And we also have an arterial line that we can collect ABGs, and we can also collect blood from the arterial circulation. And what this allowed us to do is to, in a very small group, because as you can see, this is a very invasive test. In a very small group of women with LAM, we did a level 3 CPET, cardiopulmonary exercise test, and we found that it is possible that the complaint of fatigue is related to skeletal muscle mitochondrial limit. So mitochondria is basically the engine of a cell, and the engine has to be able to extract oxygen in an efficient manner. Otherwise, it would be counterproductive and may lead to skeletal muscle dysfunction. This is, again, away from the lung. This is muscles in the legs and the arms. And normally, when mitochondrial oxygen extraction is normal, this equation here should be equal to hemoglobin. So which is the amount of hemoglobin you have in the bloodstream. So what you will see is that oxygen extraction will keep rising up to reach hemoglobin levels. And invariably, in the few patients that we've done this level 3 CPET on, we found that the oxygen extraction is unable to get to hemoglobin levels, suggesting that mitochondrial dysfunction is could be a pretty big contributor to fatigue in LAM. Now, this is really not a problem only in LAM. Whether it's different, meaning the contributors to the problem are different or not, we don't know. But we know, for example, that in patients with COPD, chronic obstructive pulmonary disease, that patients also complain of skeletal muscle dysfunction. And again, these are supposed to be lung diseases. Why are patients complaining of skeletal muscle dysfunction? Whether it's because they're out of shape, whether because they're so sick they can't eat very well and their body is using the protein of the muscle, we don't really know. Whether there is actually reactive oxygen species like hydrogen peroxide that's circulating and leading to skeletal muscle dysfunction, again, we don't know. But there's an element to suggest one, the other, or all these things combined contributing to skeletal muscle dysfunction and fatigue in disease like COPD. And in this slide, the authors suggest ways that we can deal with it. You can start with optimizing diet, and then exercising, increasing muscle endurance, increasing muscle strength, and then hopefully in the hope of reconditioning and improving shortness of breath and improving skeletal muscle dysfunction. Whether this will work in LAM, we don't really know. Whether some of these elements are contributing to fatigue in LAM, again, we don't really know. And part of the problem is that we don't really quite understand the association between life events and a diet, exercise, quality of sleep, anxiety, stress. We don't understand the contributions to any or all of these elements to the development of fatigue in LAM. And in order to treat fatigue, we need to understand these things. So we designed an app, a mobile app, to track and study fatigue in LAM. This was done in collaboration with the Worcester Polytechnic Institute. It's the team of Dr. Tulu, Bengesu Tulu at WPI. These are fantastic 4 brilliant undergraduate students who actually tackled this project. I'm gonna shout out their names: Olivia Gulesian, Evan Lebeau, Ken Snowdy, and Ilana Zeldin. And what they did is they actually first talked to me, which was not very helpful, about what I think are important things to include in the app and which should we study in the app. And then they came up with broad design of an app, and then they talked to LAM patients and asked them what's important to them. And then they went back to the drawing table and changed the app based on the feedback of women with LAM. And after they changed the app, then they talked to LAM patients again and showed them the second version of the app. And then they came up with the final version of the app. And I'm gonna show you a demo by Kevin. This was the graduation project. So let me show you the app. And again, it's work in progress. So we're not really sure that this is gonna be the final version. But what we're in the process of doing right now is to get IRB approval to finally really test and collect data from women with LAM to try to understand the contribution of life events to fatigue, see if that will help us manage the problem a bit better. So hopefully this starts, okay. Can you see it now?
Yes.
All right, sorry about that.
We can't hear if there is an explanation. We can't hear it.
I'm sorry, you cannot hear the speaker from the...
Yes.
Huh, okay.
You can see the pictures.
Yeah.
Let me try now.
Okay.
Can you hear now?
No.
Perhaps you could just show the pictures and talk us through it.
Okay, so let me try to do that. All right, so I'm gonna just back up for a second. Do I have time to go back up for just a second?
Sure.
All
We
right.
can go back. Yeah.
All right, so this is the demo of the app. This is hopefully the version that will be tested on our current cohort of women with LAM. So the login screen will have a user ID and a password. So the app will be actually linked to the medical record. So a lot of information will be garnished from the electronic medical record. So on the initial screen, there'll be, you know, are you on rapamycin? Do you take oxygen, inhalers? But we would have a lot of that information from the electronic medical record. Then once the account is created, then the main home screen will have mainly 4 buttons: the morning check-in, the evening check-in, monthly, and then if they have fatigue at any point in the day, they can just hit fatigue and then report that fatigue so we can better track it. And how do you feel? And it goes from like great to awful when you wake up in the morning. And then you can indicate the stress level, the pain level, from 0 to 10, and it's a sliding bar. And then if there's any other comment, you can add them there. And then after that, it asks you if you feel fatigued in the morning, the minute you wake up, from not at all to overwhelming. How many hours of sleep? And then questions about the sleep quality. You know, I have difficulty sleeping, or, you know, I had cough, or I woke up to use the bathroom. And then obviously some comments at the bottom there. So this ends basically the morning check-in, which is pretty quick. We don't want to add too much information because otherwise the compliance will be not so great. And then the evening one will ask how the day was, the stress, the pain. Again, sliding bar, you can always add comments. And how was the fatigue? Not at all overwhelming. And then some information about water intake. So if you click on the question mark, it gives you an explanation about what does it mean, what 0 to 2 cups or 3 to 8 cups. And then this is about the water intake. How much exercise did you do today? Were you vigorously active or just not so much? The diet got really complicated to design, but this is eventually what was agreed the majority of women with LAM, sugar, fruits, carbs, protein, from less to more compared to their average normal daily intake. Right. So after completing this, this ends the evening check-in. And then the monthly check-in will be basically just about the entire month. It, of course, will ask about the range for the menstrual cycle, see if fatigue actually correlates with the menstrual cycle. And then just general health questions. Have you been in the emergency room? Have you seen your doctor for LAM or non-LAM reasons? And just put in the comments. Again, this is all linked to the medical record, so that information. And then the last questions are about the SF6D, which is a quality of life questionnaire. We got permission from the University of Sheffield to use the SF6D to allow us to understand quality of life and the contribution to different life events, emotional well-being, social well-being, in pain, etc., and to understand if any of these actually were linked to fatigue over the past month. Did any of these events occur? So this big button, basically, anytime during the day, if there's an event that fatigue, you can just click on it and then report fatigue. And add comments. Obviously, if you're tired, you don't want to fill a big questionnaire, so we limited that to just one question. So this allows the user to customize their own profiles, but also, and more importantly, it allows the user, individual women with LAM, to actually look at their own reports. So they will see their own fatigue, they can track their own fatigue, and they can track it through the months, the year, or a week, but they can also themselves correlate it with their water intake, they can correlate it with stress, they can correlate it with activity. So they can begin to get some idea about what are the contributions of their own life events to the development of fatigue. So we are hoping to roll this out soon. We're in the process of getting IRB approval, which obviously was complicated by COVID. And the Brigham IRBs basically entirely dedicated to COVID clinical trials right now. But in a nutshell, we're hoping to try to get some understanding of fatigue and the contribution of life events to fatigue in women with LAM and TSC LAM. I just want to end by thanking everybody who's worked on these projects, on the BWH LAM Center, Lisa Hinsky, Shifal Ibakwe, who's our extraordinary research coordinator, my long-term mentor and colleague, Joel Moss at WPI, and obviously the University of Sheffield for giving us permission to use the SF6D to look at quality of life in this app. And with this, I'm going to end here and hopefully answer some of your questions.
Well, that was great. Thank you very much, Souheil. So we have a couple of questions from the audience. So perhaps if we start with those. Fairly specific. One from a lady who says that for 2 years she took sirolimus, but was still deteriorating. So she was swapped to everolimus. Unfortunately, that didn't work. She's currently reached a stable stage. I think she means of FEV of 35%. And the question was whether she ought to try sirolimus again, whether it's worth going back.
Sergio, you want to take that? All right, I'll take a stab at it. So obviously, whatever we say here cannot be construed as, medical advice, because obviously we don't know you, we don't know the history, we don't know what the levels of sirolimus were kept at when you were declining on sirolimus. There's many factors that will go into that decision. The reality is, whether it's sirolimus or everolimus, there's going to be a small percentage, but yet that percentage exists, of women with LAM who are not going to respond to either of those. And the medications are not necessarily always interchangeable. There's a very good chance that if you respond to one, you won't respond to the other, and vice versa. So if sirolimus was not effective, everolimus could be, and vice versa, for reasons that we don't quite really understand. They're really supposed to be just cousins. But my preference, if you're declining on both, is to go back to sirolimus, simply because I think we have a much better ability to control the therapeutic range of sirolimus than we do with everolimus. It's much easier to measure levels of sirolimus than it is to measure levels of everolimus. We can do 3.5 milligrams. There's actually a liquid solution of sirolimus that allows us to titrate things up and down a little more finely than we can with everolimus. Again, assuming that, I'm not talking out of order and I did not mess up your medical history, and your doctor should really be making these decisions, and please do not construe this as medical advice.
Okay, we get the caveats. Thank you very much. And then another lady who's worried about her 17-year-old daughter, who's got 3 SAGAs and is taking everolimus for the SAGAs, but has unfortunately a side effect of fatigue. She's concerned that if her daughter also got LAM, whether that would add to the problems, although kind of my experience is that she's much less likely than to get LAM while she's already on everolimus, but perhaps you could say what you think. I think Sergio's offline.
Can you, yeah, no, I think he's muted. Maybe if he unmutes. Sergio?
Yes.
Yeah.
So, did you hear the question, Sergio?
No, sorry. So
right.
I have some time. The connection is not perfect, so sorry for that.
Oh, okay, no worries. It's about a 17-year-old girl who's having everolimus for SAGA, and that's caused fatigue. Her mum was concerned that if she then developed LAM on top of that, that might double her fatigue. But and the question is whether they're independent risk things, and really how likely she is to get LAM already being on everolimus.
I mean, the patient is already on everolimus, so if she will develop LAM. LAM should be managed by the treatment, should be in some way stopped by treatment, and I'm not sure. I mean, it's a very hypothetical question, and it's different in medical field to deal with hypothesis. But if the patient will develop LAM, it's not sure that the degree of fatigue will be increased or not, depending on the degree of the disease. Probably, if LAM will limit her exercise, her ability to move, and so on, but not strictly by fatigue. So I'm not sure I've given the right answer, but probably it's difficult to endeavor this situation, imagine the situation.
Okay, thank you very much, and we hope that it's less likely to happen anyway. Okay, and then another question, and this is probably one for Souheil, about fatigue. And the questioner is asking about what's understood about the differences between fatigue caused by Sirolimus or everolimus and fatigue caused by LAM, and are there different ways of counteracting them?
Yeah, I mean that's a tough one, especially in women who develop fatigue in random order, meaning like you got prescribed an mTOR inhibitor, and then after that you started developing fatigue. Now it's easy to blame the mTOR-I for the fatigue, but sometimes the relationship is really not that linear. Again, like we discussed, you know, mTOR inhibitors can cause fatigue even outside the context of LAM. I don't think you can clinically differentiate one from the other. That, you know, the fatigue related to LAM could be, you know, chest wall fatigue or muscle fatigue versus the fatigue caused by an mTOR inhibitor. It will be very difficult to draw that line. You know, the truth is, if it's temporarily related to the initiation of an mTOR inhibitor, it's possible that it's linked to the mTOR inhibitor. But before making any decisions about changing it, you know, one has to weigh it in, right? You know, depending how debilitating the fatigue is, mTOR inhibitors will do fantastic things to lung function overall. So it will stabilize lung function, which is supremely important. So coming off of them because of the fatigue, which I understand sometimes can be debilitating, is a pretty tricky conversation. Sometimes lowering the dose of an mTOR inhibitor could help. So there's some, you know, margin of error in the levels where we keep mTOR inhibitors that may help with stabilizing LAM and improving the symptoms of fatigue.
Okay, thank you very much. And then perhaps a question you could both comment on. It's fairly short. It's what about sport and LAM? Any recommendations?
It depends on the degree of pulmonary function abnormalities. And it can be measured by 6-minute walking test and by cardiopulmonary exercise test. And if there is not a major contraindication, people can do all exercise and all sports. So it's much depending on pulmonary function testing, in my opinion, and in personal tolerance that is very widely variable.
Thank you very much. And then perhaps we could go on to a tricky question about pregnancy.
Yeah.
And the actual question is, the lady's been advised against pregnancy, but she knows that sometimes they can be successful. And it's could you talk in general about how you would handle or advise about pregnancy in patients?
Unfortunately, we cannot predict which pregnant patient will worsen with pregnancy. So it's very difficult to predict if someone will go worse than another one. And certainly I will try to suggest to avoid pregnancy in patients with more advanced disease. In the other patient with an early disease, it depends if the disease is progressive by itself or not, if the patient is already needing a treatment with sirolimus or not. So the advice is very different from patient to patient. It's quite difficult to have a general idea, except that the fact that we do know that some patients progress also significantly with pregnancy. Said that, to answer the question in a more precise way, there is no a way to predict which patient will progress and which one will not progress during pregnancy.
Okay, I think that's very clear.
If I just may add something, there's been a 2 or 3 recent reports that successful pregnancies on an mTOR inhibitor. Again, this is a huge conversation to be had between patients and their doctors if they're willing to undergo pregnancy while on an mTOR inhibitor. But the reports of successful pregnancies are out there now with mTOR inhibition.
I do agree. It's not an absolute contraindication. By the way, there are patients that become pregnant after transplantation and are treated with mTOR inhibitor. So the problem is more the disease itself and the treatment with mTOR inhibitor. I agree.
And then there's a specific question about cough from a lady who has a lot of very difficult cough, making it difficult for her to talk. And she was asking if there's any specific therapies that would help cough in LAM.
Short answer is no. More elaborate answer is going to be linked to, is there any evidence of reactive airways disease? Is there a pretty big bronchodilator response on your pulmonary function test? Is that a contributor to cough? Has other reasons of cough been excluded? You know, reflux, postnasal drip, right? Once we've done the basic homework of excluding other reasons why patients can be coughing, because cough is not very universal in LAM, so one has to make sure that there's no other things that can be excluded. Once that's done, then I think it's a conversation about risk-benefit ratios. In our other interstitial lung disease patients, there are some drugs that are not usually prescribed for cough that we've tried that work well. At the risk of giving medical advice over Zoom, like for example, gabapentin, which is used for peripheral neuropathy, works very well for cough in IPF. So it may be something that worth a try. But again, first things first is to exclude other contributors of cough that are not LAM related.
Yeah, thank you very much. And another very reasonable question from the audience was, apart from stopping or lowering the dose of the mTOR inhibitor, is there anything else that can be done for fatigue that we know about?
Unfortunately, I feel like I'm in clinic again, saying that I feel and I understand, but I really have not much to offer. Again, assuming that, you know, the thyroid function is okay and all that stuff is okay, there's unfortunately not a whole lot that we know to do for the debilitating fatigue of LAM. And again, it's a major issue that we need to do better with.
And is it related to pre-existing fitness? I mean, should all children with TSC be exercising to improve their muscle mass and tolerance?
I think so. I mean, I concur with Sergio that exercise is fantastic as long as it's done safely. And by safely means, you know, if you do your absolute best of keeping your oxygen saturations above 88 or 90% anytime you're exercising. Under those conditions, I think that everybody should be exercising. Whether or not it improves fatigue, I don't know. But what I do know for sure is that, you know, the next time any of us get a cold or is in bed for whatever minor illness or major illness, the better shape you're in going into it, the better shape you're going to be coming out of it. So, you know, if you have a cold and you have to be in bed for 3 days, the more muscle strength you have, the more in shape you are, the more likely it is 3 days later or 4 days later or whatever it is that time you spend in bed or in a hospital, the more likely it is that you're going to be in better shape coming out of it. And it might be the difference between, you know, going home or going to rehab. The hypocrite in me says everybody should exercise.
Okay. And another very quick question about the LAM app or LAM tracker app is whether it's or where people would go to enroll in it when it starts?
Yeah, so this is, this is super tricky in terms of information security. Our hope initially is to roll it out at the Brigham because the data are going to be saved offsite, and to make sure that there's no violation of the breach of the electronic data. It's first is going to be limited to women with LAM who are seen at the Brigham, to make sure that we can absolutely control the safety of the data, especially if the data are going to be linked to the electronic medical record. This is obviously a huge issue of personal information safety. Once we're sure of that, and once our Brigham IRB allows us, then we may be able to extend the use of the app. We are happy to share the app with other sites who are willing to go through their own processes of IRB and make sure that their own information security is safe in terms of storing the information. But for now, unfortunately, at least in the beginning, it will be limited to the Brigham.
Mm-hmm. Okay, and probably a question for both of you about, are there any differences between TSC1 and TSC2 regarding LAM?
LAM is more likely to happen in TSC2 than it is to happen in TSC1.
Mm-hmm. Yeah.
Yeah.
So that's the same with renal AMLs as well, which happen earlier and are more likely to be troublesome in TSC2 than TSC1. Someone asked a question. I don't know what it means, but I think you will, because it's for you, Souheil. Any updates on lymphatic LAM, research or general knowledge updates?
Not sure I understand what it means. Probably regarding the lymphatic involvement, that can be a major issue in some patients, and usually those patients respond well to mTOR inhibitor.
Okay, well, that's it. And then a question from a man whose wife's LAM has TS LAM has stabilized with Sardimus, and who's not on oxygen. And the question is, can she travel by aeroplane or should she avoid it?
We know from a recent study published by Swiss colleague Roman Lazare that there are still an increased risk for traveling by flights in LAM patients, also in status 1 of pneumothorax, that can happen also in the days after the flights. And of course, it is also related to the duration of the flight, and if it's a very long flight or a short flight in the same country. So the answer is if the patient did not have recently pneumothorax, she can fly, but there is a slight increase of the risk of a pneumothorax compared to the general population.
Okay, thank you very much. There was a question, again, a difficult one, about whether fatigue can be assessed in someone with autism. And I don't know if you have any experience of that in the clinic.
Yeah, unfortunately, it's a major problem. The general major problem of evaluating, LAM in patients with the tuberous sclerosis complex related neurological disorders, right? It's not easy to do a pulmonary function test. What may be easier is to do a 6-minute walk, right? Then doing a pulmonary function test. The 6-minute walk and the walk distance will give us a sense about, compared to normal, where we are in terms of exercise tolerance and ability to walk, and that could hopefully be tracked over time. But the neurological involvement in TSC does render some of the understanding of the degree of dysfunction quite challenging.
Thank you very much. That's fantastic. So we're getting towards the end of time. There's one last question that's coming. I'd just like to ask it, and that's about COVID and LAM, because the questioner, like many patients, are very scared of getting both. Do you have any specific advice for them?
We do not have any data that suggests that patients suffering from lung diseases are at higher risk to have COVID-19. Of course, if a patient with an important lung disease develop COVID-19 pneumonia, it can be worse than compared to a healthy subject. Said that, we do not have any really additional data, no data on LAM patient. In our experience that we have now, I think more than 150 patients followed, we did not have any LAM patient that developed COVID-19 disease. And I must say we had very few patients also with other lung disease. I do not know the reason. There are also some speculative ideas regarding particular patients like asthma patients that say that we do not have a lot of patients with underlying lung disease admitted for COVID-19. I do not know if in Boston it was the same experience.
Yeah, so I mean, I agree. We have a large transplant center. We have a lot of interstitial lung disease, obviously a lot of LAM as well. I just think in general, pulmonary patients have been preparing for this their entire life, in the sense that, they know how to take precautions. They know how to avoid, they're professionals at flu season. They're professionals at trying to avoid a cold. So I think that in part may be playing a role in how few of lung transplant, cystic fibrosis, and certainly LAM patients we've seen with COVID-19. I don't think that in our experience, there hasn't been any other explanation that we can think of about why they are protected other than they know how to take precautions.
Thank you. That's very reassuring. I'd just like to hand over then to John for a last word, and then Carla and Mika for their bit. Thank you very much for the talks.
Thank you, Chris.
Thank you.
As I was listening to the talks and the questions and answers, I was thinking, what could I possibly say to finish this last words? The talks were fabulous. And I realized something that is really useful right now. Everyone certainly focuses on COVID-19 and the risks, and it causes a great deal of anxiety. But this seminar really was about hope. We had a fabulous talk about research and new therapies, ways to make the disease better. And then, honestly, it was brilliant to look at the fatigue aspect, because LAM and TS, they're not really just diseases of the signaling pathway. They're diseases of patients and the symptoms they have. And so I thought these talks were absolutely fabulous. And I'm very grateful for Mika and Carla and for both speakers for giving us such a fabulous talk and give us such hope. And so with that, I'll thank you again and pass this off to Mika and Carla.
Yes, I don't think we could agree more with you, John, there. I think all that's left to say from Mika and I is a really big thank you, especially to the presenters of today's special session, Drs. Sergio Harari and Souheil El-Chemal for your fantastic talks. That really was incredible. We'd also like to say a massive thank you to our mentors, Drs. John Bisler and Chris Kingswood, for being there for us, putting up with us and guiding us throughout the DEA pit stops. And ultimately, the DEA World Forums. We couldn't have done this without you. A world of thanks also to all of the doctors and key opinion leaders, past, present and future, who have joined us along our journey. And we would like to thank all of those who registered for the DEA World webinars, all the TSC associations for their assistance in organising the numerous meetings across the EU and now in web format. And I think that if I've forgotten anything, Mika can definitely chip in.
Thank you. Yeah, we would like to thank also the LAM organizations for divulging information for us for this important session. And last but not least, thank you the individuals with LAM and TSC and their families for coming for the meetings and giving us the strength and courage to move forward with our ideas. And I really hope that you got a lot of information from this session, and have a wonderful rest of the day, evening for everyone. Thank you very much, everyone.
Thank you. Thank you so much.
Thank you very much.
Thank you.
Thank you so much. Goodbye to everybody.
Thank you. Bye-bye.
Ciao, ciao.
Thank you.